So this is about respiratory physiology from IVMRCS. Let's see what are the important points given and concern questions for this. This is the intraalveolar means intrapulmonary pressure. Is pressure inside the lung and alveoli. In relation to atmosphere, it's always negative. During inspiration, it is -1 millimeter of Hg. End of inspiration 0. During expiration +1. End of. Intrathoracic pressure, that is the intrapleural pressure, is maintained by pressure of the fluid within this space. Intrapleural pressure is between two layers of the pleura. It is always negative except in Valsova maneuver. This is the question. Whenever you try to do Valsova maneuver, that becomes positive pressure inside the intrathoracic pressure, or you call it as a intrapleural pressure. So static volume capacities. What is tidal volume? These are the three important things: tidal volume, reserved volume, and the vital capacity. Tidal volume is volume of air inspired and expired normally. If you see this, inspiration and expiration. Inspiration is upper and expiration is lower. So this much will be tidal volume. It's always around, roughly it is around 500 ml per minute. Volume of air inspired during rest is also called as pulmonary minute ventilation. Volume of air moving in and out during respiration. The quantity is 500. Respiratory residual volume is after full expiration. Volume of air remaining in the lungs after maximum expiration. A person has expired maximally. So this is maximum expiration, this is maximum inspiration. Upper part is inspiration, lower part is expiration, and this is normal. So expiratory reserve volume, this much he can expire, this much a person can inspire. So even after this, whatever volume is there, that is called as residual volume. So diagnose obstructive lung disease. Volume of air remaining in the lung after maximum expiration. Diagnose obstructive lung disease decreases residual volume. So whenever there is some sort of obstruction, this residual volume is increased, because this violet color, that is residual volume. So a person is unable to maximally expire, so this will increase. Then vital capacity is maximum inspiration, maximum expiration. So if inspiration and expiration, that is vital capacity. So you can see a person is having, this is about, if you see measure the quantities in liters, here it is 0 liter is 0 to 1000 and above. This is 1000 something 1200. You can see it is about here. Tidal volume, this is roughly, you can see this is 2000, 2500, 3000, around 500 ml. So a person from this 500 to this much, he has got reserved volume for expiration. Again you can see this is 1000 is here, 1000 to 1200 something here, 800 plus 500 around 1300 ml is this the rough idea. Expiratory reserve volume. And if you see here from 3000 to 6000, this is around 3 liters. 3 liters, around 3 liters is the inspiratory reserve volume. If a person is taking deep inspiration, so more 500 is a normal thing, but he can inspire more 300 liters, 3 liters more inside. That is inspiratory reserve volume. And he can expire around 13 to 1500 liter more air. So total vital capacity is this 3 liter, this 13 and 500. You can see around 5 liters of the air is the vital capacity. Vital capacity, this is around 500. And if you add residual volume in that, 6 to 6.2 liters is the total lung capacity. So just try to understand, normal is tidal volume 500 ml. More air a person can inspire is more than 300 ml, 3 liters more he can inspire, and around 1300 to 1500 he can expire, and residual is again 1200 ml. So this is about the now forced vital capacity. Vital capacity is total inspiration and expiration. Fraction of vital capacity expired in seconds using maximum expiratory effort. So FEV1 is forced vital capacity. Fraction of vital capacity expired in seconds. In first second it will be how much percentage a person is able to expire. If it is up to 83% in 1 second, it's normal. In second 94%, in third second 97%, means nearly 100% a person is able to expire whatever the forced inspiration is done. So that is the normal value. So if you measure the ratio of forced expiratory vital capacity in 1 second divided by forced vital capacity total, so if it should be less than 80. It means a person forced vital capacity, fraction of vital capacity expired in seconds using maximum expiratory after deep inspiration. So vital capacity is deep inspiration and expiration. So in 3 seconds he has to do it equal. In 1 second it has to be roughly about 83%. So out of this, if it is 83%, it's okay. If it is less than 80, it means, and if it is more than 80, what does less than 80 means? He is unable to expire in first second 80% of the force vital capacity. So whenever there is obstructive, he is inspiring but he is in obstruction. So that is bronchial asthma, emphysema, COPD, bronchiectasis, laryngeal malignancy. So these are obstructive diseases. The ratio of FEV1 to FEC will less than 80. If the ratio is increasing, means in first second he is expiring more than 80%, it means he is having alveolitis, lung collapse, edema. This is restrictive type of disease. So obstruction, this is obstruction. Restriction means for inspiration it is coming less. So much part is expiring within 1 second. So in this both the things will go down. Forced vital capacity will also go down. Denominator will go down. That's why FEV1 will be remaining same. So here denominator is going down. Here numerator is going up. First second he is expiring maximum. Denominator is. So if you see FEV1 is less than 1 liter. In first second less than 1 liter. And FEV1 to FEC is 90% used to assess risk of morbidity in thoracic surgery. If it is less than 1 liter, that is risky. So difference between obstructive and restrictive lung disease, what will happen? Forced vital capacity. This is the vital capacity. Maximum inspiration divided by maximum expiration. If there is obstruction, definitely will go down. But if it is restriction, both it will go down to much extent. If normal vital capacity is supposed to be, we have seen 5 liters. In obstructive and restrictive types, this may go to 4 liter. In restrictive type, it may go to 3 liters. And what will happen in forced expiratory FEV1? This is vital capacity. And if you see FEV1 in 1 second, in obstructive, this will be more decrease. In restrictive, this will be less decrease. So FEV1 divided by FVC ratio will be less to some extent, but in this will increase, because here denominator is decreasing. Denominator, forced vital capacity, this is increasing to more denominator. This upper part is denominator. So what will happen? Residual volume will increase in both the conditions. Total lung capacity will remain in obstructive lung disease normal or will increase. In restrictive, it will be definitely decreased. Functional residual capacity will increase in obstructive, and in restrictive it will decrease. So what are the effects of obesity on pulmonary function test? Expiratory reserve volume. A person is expiratory reserve volume. So there will be reduction in all the things. Functional residual capacity will reduce, functional total lung capacity will reduce, vital capacity will be reduced, forced expiratory volume in 1 second will reduce. This everything will be reduced in peak expiratory flow rate. PEF1 is the maximum flow rate generated by forced expiration detected by peak flow. Normally, say 400 to 700 liter per minute. Males, female, athlete, height of the body. Heighted person, P will be more. What is the role of surfactant in this? Surface active agents secreted by type 2 pneumocytes. These are secreted by type 2. Mechanism is they decrease the surface tension to prevent collapse. What is lung compliance? It is expansibility of the lung. Any hollow organ has got compliance. Decrease in lung compliance means the sponginess has decreased, except in emphysema and old age. Increased compliance means lungs are easily to expanded. Work of breathing is work done during inspiration. Normal expiration is passive process. It is because of elastic recoil of the lung. That is expiration. But inspiration is an active process. Elastic work. 65% of work required overcoming lung elasticity and surface tension. Non-elastic airway and tissue resistance. Factors affecting all diseases increase work of breathing, but tracheostomy will definitely decrease the work of breathing. Dead spaces means what are the dead spaces? Part of respiratory tract which has gas exchange doesn't take place. So these can be anatomical or alveolar. Anatomical air passages down to respiratory bronchiole. 150 ml is the normal dead space, which can be increased by sympathetic, which increased by sympathetic as a bronchodilator as adrenaline decrease and decreased by tracheostomy. Whenever there is, so this is the dead space. Alveolar air present in the non-functioning alveoli is minimal. So what is VQ mismatch? Ventilation, perfusion. V is ventilation, Q is perfusion. Ventilation decreased by lung diseases. Any lung disease, this decreases ventilation. Perfusion is decreased by pulmonary embolism. There is no exchange of the gases. Ventilation is just transfer of gases inside. Whenever there is pulmonary embolism, ventilated gas divided by perfusing gas, if suppose they are equal, so ratio will be normal. If denominator is decreasing, perfusion is less, so VQ ratio will increase. So in pulmonary embolism, VQ ratio will go up because perfusion is going down, so VQ ratio will go up. What is oxygen dissociation curve? On the right side, there is oxygen partial pressure of oxygen. On the left side, this oxygen saturation of hemoglobin. This gives affinity of hemoglobin to oxygen. In other words, you can say how much hemoglobin is releasing oxygen to the tissues. If the hemoglobin is more affinity and less releasing oxygen, less the oxygen is released to the tissues, it means it is detrimental to the body. So shift to the right and shift to the left. Shift to the right is always helpful. It means that more oxygen, easily oxygen is released to the tissues. It will happen in a conditions as a body protective mechanism. So affinity to oxygen by hemoglobin is decreased. It means more oxygen will be provided to the tissues. Whenever there is increased partial pressure of carbon dioxide, acidosis respiratory acidosis, there will be shift to the right, body will try to release more oxygen to the tissues. Whenever there is acidosis, pH is decrease, hydrogen ions are increased. Whenever there is 2,3 dpg is increased, whenever temperature is increased, all these conditions make shift of the oxygen dissociation curve to the right. This is Bohr effect, and opposite to this is shift to the left. Shift to the left is more dangerous, low left load, and right is raised right release, oxygen release. So cadet phase right, that is the Bohr's effect. Increase, C is for carbon dioxide, A is for acidosis, D is for dpg, E is for exercise, and T is for temperature. Cadet phase right. This is Bohr effect. More oxygen supply to the tissues, decrease affinity. And you see, shift to the left means less oxygen affinity is there. It is opposite of all this. A person is at the high altitude, less temperature, there will be shift to the left. Oxygen will remain bound. Hypoxia is deficient of oxygen delivery to the tissues. There are 4 types of hypoxia. Hypoxic hypoxia due to lung disease and high altitude. Already there is less oxygen content. So that is hypoxic hypoxia. So anemic hypoxia, when decreased hemoglobin, so decreased oxygen content, low oxygen saturation. Stagnant hypoxia due to blood flow is reduced. Histotoxic, tissue can't utilize oxygen because of cyanide poisoning. All these are reasons to cause hypoxia. CO2 transport, physical form is carbon dioxide dissolved in the blood 10%. Chemical form is bicarbonate, either sodium bicarbonate in RBCs, carbon amino acids, or plasma proteins. Relation between oxygen and carbon dioxide. CO2 and oxygen carried on the different sides by hemoglobin, oxygen with the ferrous atom and carbon dioxide with the amino acid groups, but each affect each other. Binding of carbon dioxide with hemoglobin causes CHP to displace from the tissues, that is Bohr effect. Binding of oxygen with the hemoglobin causes CO2 to be displaced, that is Halden effect. Where are the respiratory chemoreceptors? We have seen these are the chemoreceptors located in aortic and carotid bodies, stimulated by decreased partial pressure of oxygen, acidosis, and central chemoreceptors are located in medulla, stimulated by partial pressure of carbon dioxide. Aortic chemoreceptors. It is important in long-standing COPD with persistent increased CO2. Patient may be accustomed to increased CO2, therefore depend on decreased oxygen stimulus respiration, that is called as hypoxic drive. In COPD patient, receiving high oxygen flow causes acute respiratory failure. This is a question most commonly asked. COPD patients is always acclimatized to the higher level of carbon, that is called as hypoxic drive. So 100% oxygen is avoided to give patient of COPD. Nitrogen is the inert gas present in mixtures and has an important role in preventing lung collapse. So what are respiratory failures? There are 2 types of respiratory failures, type 1, type 2. Type 1 failure as pulmonary embolism, there is low partial pressure of oxygen only. And type 2 respiratory failure is COPD, where there is low partial pressure of oxygen, hypoxemia as well as hypoxemia. Carbon dioxide is also high. What is mechanical ventilation? It is ventilation induced by apnea, respiratory rate. Whenever there is respiratory distress, respiratory rate more than 35, partial pressure of CO2 goes above 8, partial pressure of oxygen goes below 8, Glasgow Coma scale is less than 8, intubate the patient, surgical induction, head, chest and facial. So this was about respiratory physiology from IVMRCS.